Dear students, this is a lecture on periodontitis. I am Dr. Rajkumar, Head of the Department of Periodontology, Penang International Dental College. Let's go into the class. So these are the learning outcomes for today's lecture: chronic periodontitis and aggressive periodontitis. The learning outcomes for chronic periodontitis are: identify the etiological factors for chronic periodontitis, list 3 microorganisms concerned with the chronic periodontitis, describe various clinical and radiographic features of chronic periodontitis, and outline various treatment plans for chronic periodontitis. When it comes to aggressive periodontitis, classify aggressive periodontitis, explain the microbial etiology of aggressive periodontitis, and describe the clinical and radiographic features of aggressive periodontitis, and outline the treatment for aggressive periodontitis. Coming on to definition, what is periodontitis? Periodontitis is an infectious disease resulting in inflammation within the supporting tissues of the teeth and progressive attachment loss and bone loss. According to Wolf, periodontitis is defined as an inflammatory disease of the supporting tissue of the teeth caused by specific or a group of specific microorganisms, resulting in progressive destruction of the periodontal ligament, alveolar bone, with increased probing depth and recession, or both. So this periodontitis can be classified into chronic and aggressive periodontitis. The alternative name for a chronic periodontitis is also called as adult periodontitis. So we will see about chronic periodontitis first. So these are all the terminologies we are going to see under chronic periodontitis: horizontal bone loss, vertical bone loss, periodontal pocket, clinical attachment loss, clinical attachment level, recession and furcation involvement. Let's go on to chronic periodontitis. Basically, the chronic periodontitis is classified based on the location into localized chronic periodontitis and generalized chronic periodontitis. Localized chronic periodontitis is classified based on if there is less than 30% of the site affected with attachment loss and bone loss, it is called as localized chronic periodontitis, and if the attachment loss and bone loss is more than 30% of the sites, then it is generalized chronic periodontitis. Here we mentioned it as sites. Sites is basically the number of sites you probe in the oral cavity. Each tooth we usually probe 6 sites: mesiobuccal, midbuccal, distobuccal, mesiolingual, midlingual and distolingual. So these 6 sites consist of single tooth. So there are 32 teeth, and all 32 teeth into 6 times, that is what the total number of sites. So when you calculate the total number of sites involved, if it is less than 30% of the sites involved with periodontitis, then it is called as localized, and if more than 30% of the site involved, it is generalized periodontitis. Based on the severity, it is subclassified into mild, moderate and severe periodontitis. Mild periodontitis when the attachment loss is between 1 to 2 millimeters, moderate periodontitis when the attachment loss is 3 to 4 millimeters, and severe periodontitis when the attachment loss is more than 5 millimeters. Here I am classifying chronic periodontitis based on the attachment loss, not on the probing pocket depth. Don't confuse with pocket depth and attachment loss. Attachment loss is detachment of the junctional epithelium from the CEJ. Whenever the CEJ moves apical to the junctional epithelium moves apical to the CEJ, then it is attachment loss. Either it may be because of pocket or may be because of recession or combination of both. Anyway, whenever there is a movement of junctional epithelium apical from the cement enamel junction, it is attachment loss. Coming on to the symptoms of chronic periodontitis, usually it will be painless. Occasionally there will be a pain which is a localized dull type of pain, and patients may have gingival tenderness and itching. Coming on to stages of chronic periodontitis, the disease will progress in burst of activity of unknown duration if untreated and can exist in active and inactive states. So there are two stages of chronic periodontitis. One is stage of activity and stage of inactivity. During the stage of activity there will be active destructions happens, and during the stage of inactivity there will not be any destruction happens. The pocket stays at the same level. So the chronic periodontitis is not a continuous disease process. There will be some period of activity and some period of remission or quiescence, which is there is no inactivity. During the active period there will be destruction. During the inactive period there will not be any destruction. But we don't know how long the active period will be and how long the inactive period will be. It may be a week, it may be a month, it may be years also, the activity. And the inactivity also the same way. The inactivity may be in weeks, months or years. That depends on patient. It varies for patient to patient, site to site. It is not uniform in all the sites in the oral cavity, and it is not uniform for all the patients with chronic periodontitis. Some patients will have the active stage which is for a week. Some patients will have the activity for month. So it cannot be predictable. Coming on to the etiology, chronic periodontitis, the disease is multifactorial etiology, but the primary etiology is microorganisms. Microorganisms is the primary etiology for chronic periodontitis. When it comes to microorganisms, there are a lot of microorganisms involved. Most frequently involved microorganism responsible for chronic periodontitis is the red complex organisms. Why it is named as red complex organisms? Because it is going to take blood as its food, because these organisms grows with protein. Unlike your streptococcus organisms which requires a carbohydrate for its growth, these red complex organisms requires proteins. So these organisms takes proteins from the blood, so only it is named as red complex organisms. And most of the time whenever these organisms are present, there will be bleeding and probing. So these red complex organisms are kept at the top of the pyramid. Three organisms: P. gingivalis, T. forsythia and T. denticola. PG, TD and TF. Coming on to the risk factors. The risk factors for chronic periodontitis are local factors. Primarily the cause will be the plaque accumulation onto the tooth and gingival surface. Next is the red complex organisms. I already told P. gingivalis, T. forsythia and T. denticola. So Porphyromonas gingivalis, Tenerella forsythia and Treponema denticola. These three are the main organisms responsible for chronic periodontitis. Most frequently identified organisms for chronic periodontitis. Third is the local retentive factor. Local retentive factor may be calculus or overhanging restoration, carious lesions, which harbors more amount of plaque to accumulate and bacteria to accumulate onto the site. Next is systemic factors. The systemic risk factors are patient health conditions like diabetes. Diabetes is one of the prime cause for periodontal disease. The diabetes increases the severity and extent of the periodontal disease. Next is environmental and behavioral factors like smoking and stress. Even smoking can have influence on the severity of periodontal disease, and the emotional stress plays some role in severity of periodontal disease. Next is genetic factor. There may be possibility of genetics involved in chronic periodontitis, but we don't have the proof for that. There is a possibility. So coming on to the characteristic features, the characteristic features of chronic periodontitis are supragingival and subgingival plaque accumulation, which is associated with calculus, gingival inflammation, pocket formation and bone loss. Gingiva is slightly to moderately swollen, color varies from pale to magenta, stippling is absent, blunted or rolled marginal gingiva, craters or flattened interdental papilla. Gingival inflammation is not visible clinically in some patients like smokers. If patient is having a habit of smoking, the inflammation will be masked. Gingival bleeding is spontaneous or it bleeds in response to probing, exudates from the cervical fluid and suppuration is found. In long-standing low-grade inflammation, thickened fibrotic marginal gingiva may be seen. Pocket depth may vary. There may be horizontal or vertical bone loss. Tooth mobility may be seen during the advanced cases. So the points to be remembered for chronic periodontitis is the probing depth measurement alone will not determine there is a chronic periodontitis. You have to identify the clinical attachment loss happened in the patient to identify it as chronic periodontitis. I already told during the definition that it is the amount of attachment loss, not the amount of pocket depth. So the measurement of clinical attachment level around the tooth provides an insight of the history and extent of periodontal destruction around the tooth. So once common pitfall of clinical periodontal examination is the direct translation of probing depth as clinical attachment level. No, that is wrong. Usually the gingival margin will be 2 to 3 millimeter coronal to the CEJ because the normal sulcus depth is 3 millimeters. So if you translate your probing depth as your attachment level, then you are going to exaggerate your attachment level. Even a 1 millimeter attachment loss will give it as 4 millimeter loss because of the 3 millimeter coronal to the cemento-enamel junction, the gingival margin. So don't estimate pocket or translate periodontal pocket directly as periodontitis. It may be pseudo pocket also. So you have to estimate the amount of attachment loss to determine the severity of periodontal disease, not the pocket depth. So coming on to the diagnosis, clinically you can diagnose chronic periodontitis by the use of periodontal probes and clinical attachment levels, radiographs to see the bone morphology. So these are some pictures showing a chronic periodontitis. The first picture shows you the pocket which results in chronic periodontitis, and second picture shows you the attachment loss without pocket result in periodontitis. The radiographs can use to assess the amount of bone loss and the type of bone loss. There is an horizontal bone loss seen and there is some calculus seen on the radiograph. You can see an arrow mark with C representing the calculus and the arrow mark with P representing the pocket and bone loss. Next is associated systemic conditions with chronic periodontitis. I already told diabetes mellitus increase the risk of periodontitis both in severity of the disease and intensity of the disease. The another associated systemic condition may be cardiovascular diseases. This because the periodontal pathogens have been identified in cardiovascular system. So there are evidence stating that the P. gingivalis can grow inside the vessels which have a relation between cardiovascular system and periodontitis. Other forms of chronic periodontitis are recurrent chronic periodontitis and refractory chronic periodontitis. A recurrent name because it is recurrence of disease after a complete treatment. Once the patient from a chronic periodontitis comes to a static state for a long time and the disease recur after the treatment. Even after the treatment, the patient in a stable state, when the disease recurs, it is recurrent chronic periodontitis. Refractory if it does not respond to the treatment. Most of the time chronic periodontitis will respond to the treatment. If you think that chronic periodontitis is not responded, it may be because of inadequate therapy given to the patient. There may be some local factors left out or bacteria left out in the sulcus which initiate the progression of the disease. That may be called as refractory. But actually, if you do a proper therapy, there will not be any refractory chronic periodontitis. All the chronic periodontitis disease will respond to a proper treatment. So next is aggressive periodontitis. So aggressive periodontitis, the characteristic features of aggressive periodontitis is otherwise clinically healthy patient. The patient will be normally healthy. There will be rapid attachment loss and bone destruction. There are chances of familial aggregation of the disease. The amount of microbial deposit will be inconsistent with the severity of the disease. You may be seeing very less amount of plaque and calculus, but there will be severe destruction. There will be increased levels of bacteria, which is specifically the Actinobacillus actinomycetum committens, anomalies in phagocytosis functions, hyperresponsive macrophages, produces increased prostaglandin E2, interleukin and beta. In some cases, it's self-arresting disease progression. So aggressive periodontitis may be further classified into localized and generalized. Here it is totally different from how we classified chronic periodontitis. We classified chronic periodontitis into localized and generalized based on the number of site involved, whether it is less than 30% of the site or more than 30% of the site. Whereas in aggressive periodontitis, the classification is totally different. The localized form is classified based on localized first molar and incisor involvement with at least 2 permanent tooth involvement, one of which should be the first molar, and not more than 2 teeth other than the first molar and incisor are involved. This states that there may be 2 permanent tooth involved, which one of it should be a first molar, and there cannot be more than 2 teeth other than the first molar and incisor. So just a 2 teeth involvement can result in localized aggressive periodontitis, and to a maximum of 8 plus 2, 10 tooth involvement. 8 tooth, what I am saying is 4 incisors and 4 molars. So that is 8. That is the calculation for localized aggressive periodontitis. Generalized aggressive periodontitis usually affects persons under the age of 30 years. Generalized proximal attachment loss affecting at least 3 permanent tooth other than first molar and incisor. So it is 3 permanent tooth other than first molar and incisor. Again, the count is different. It may be only 4 tooth where it can be classified as generalized, and maximum of all 32 teeth. Can you understand? So there may be involvement of first molar and incisor plus 3 other tooth other than first molar and incisor. Total of 5 tooth will result in generalized. Right? That is the classification of aggressive and localized and generalized aggressive periodontitis. Coming on to the localized aggressive periodontitis. So localized aggressive periodontitis, which is formerly known as localized juvenile periodontitis, the onset of the disease occurs between puberty and 20 years of age. The bone loss will be faster than chronic periodontitis, which is almost 3 to 4 times faster than chronic periodontitis, and all the time it involves first molar and incisor. The clinical inflammation may not be obvious, minimal plaque that is rarely mineralized. However, it contains elevated levels of Aggregatibacter actinomycetum committens. And another clinical finding is bilateral symmetrical pattern. The incisor molar relation will be bilaterally symmetrical. It will be a mirror-like pattern. If one side of molar is involved, the other side of the same molar will be involved. Right molar and left molar will be involved at the same amount. That is mirror-like pattern you will see in localized aggressive periodontitis. If you cannot identify a mirror-like pattern of bone destruction on both the sides, then you have to think out of the box. It's not a localized aggressive periodontitis. Most of the time it will be having a mirror-like pattern. Both the sides will be involved at the same amount, and most of the time it involves the incisor and the first permanent molar. And there will be increased mobility of the affected tooth. There will be periodontal abscess formation and sensitivity to the root surface. So it is a rapid and severe loss of alveolar bone around more than one permanent tooth, usually the first molar and incisors, characterized by interproximal attachment loss on at least two permanent first molar and incisor, with attachment loss on not more than two teeth other than the first molar and incisor. So frequently the disease is localized to permanent first molar and incisor. However, some retrospective study shows that localized aggressive periodontitis patients suggest findings of bone loss around primary tooth can be the early findings for the disease. The occurrence is otherwise in a healthy children or adolescent without any clinical evidence of systemic disease. Patients have little or no tissue inflammation and very little supragingival dental plaque or calculus. So this is a critical part where the diagnosis is going to be difficult. When you cannot able to visualize the inflammation, it is most often you leave the disease unnoticed. The disease will be left unnoticed until it reaches the severe form where the mobility starts. Mobility may be the first sign because there is no inflammation. When the patient comes to a dentist, the dentist failed to probe the sites, it is difficult to identify the disease because there is no inflammation. You will not be able to see any inflammation. So wherever there is no inflammation, you may not, or the dentist may have missed out the probing in such regions. So it is mandatory for every patient to probe all the sites in the oral cavity to identify a disease. So this is a picture of a localized aggressive periodontitis seen in the lateral incisor. You can see how much of bone loss happened, the severity of the bone loss. Coming on to the rate of bone loss, the adult periodontitis, the rate of bone loss per year is around 0.07 to 0.73 millimeters per year, whereas in localized aggressive periodontitis it is 1.08 to 1.80 millimeters per year. So almost 2 millimeters per year the bone loss will be. So by 5 years the patient will lose the teeth if the disease was not diagnosed properly at the earlier stage. So basically the bone loss is approximately 3 to 4 times faster compared to chronic periodontitis. Coming on to the epidemiology, the overall prevalence range in different regions differs. but comparatively the localized aggressive periodontitis patient cases are very minimal compared to chronic periodontitis patients all over the world. Bacterial association. Why we are saying bacterial association? Because most often we found this Aggregatibacter actinomycetum committens in the site involved with localized aggressive periodontitis. So there will be elevated levels of AA found in active sites when compared to healthy sites. There will be very less number of AA in healthy sites compared to the active sites. Why AA? Because it produces leukotoxins, collagenase and other immunosuppressive factors that helps to evade the host defense mechanism. The incidence of AA found to be greater in younger person compared to older clients. The younger clients experience more destruction in shorter period of time compared to the older patients. The importance of diagnosing this condition earlier is to prevent loss of teeth. So this is the microorganism Aggregatibacter actinomycetum committens. How does this leukotoxins affects our cell? We have studied in our second year. Your first year and second year, your preclinical subjects like your physiology and biochemistry, pathology. You must have studied about oxidative phosphorylation and mitochondrial matrix, ADP, ATP, all these things you must have studied. How this leukotoxin affects the cell is the leukotoxins kills the human immune cells, your neutrophils, by apoptosis. Apoptosis is otherwise called as natural form of cell death. After the cell survives for a period of time, it goes to a stage of apoptosis and dies by itself, where it clears off. Because of this, AA produces a leukotoxin which induces apoptosis through a mitochondrial pathway that involves decreased levels of ATP, ADP in the mitochondrial matrix and arrest oxidative phosphorylation. So the cell goes to death. Your neutrophils dies by apoptosis, which prevents action against this microorganisms. Basically, your neutrophils are first line of defense for your body. It is the human cell which is going to act against any external stimulus coming onto the body, either any foreign objects, either it is an microorganism or a non-living object, which when it comes in contact to the tissue, the neutrophils come to the site, it kills the microorganisms and engulf it, phagocytosis, and destroys it. That is how it prevents the microorganism entering the body. When this leukocytes attaches to the neutrophils, it kills the neutrophils instead of the neutrophil killing the microorganism. So eventually it evades the host mechanism. So these microorganisms go into the bloodstream, multiplies and grows. That is how AA grows in the body. But why it is specific to some sites? Why it is self-limiting, or it is only localized to some regions? Some reasons why it is affecting only certain teeth are: the Aggregatibacter actinomycetum colonize the first permanent tooth erupt into the oral cavity, which is your permanent first molar and central incisors. It evades the host defense mechanism. I told you how it evades the host defense mechanism. But following the initial attack, the host responds back to the evading the host response. When the AA evades the host response, it cannot survive for a longer time. Initially, the body will allow it to kill the neutrophils. Once the human host immune mechanisms wakes up, it started producing macrophages and try to kill the microorganisms. Thereby it prevents the microbial growth there. There may be production of antibodies to the AA. So antibodies produced which improves the phagocytosis of this bacteria and kills the bacteria. This may prevent the colonization of bacteria to the other sites. Other additional reasons for localization of the disease may be the Aggregatibacter actinomycetum commitans may loses its ability to produce leukotoxins over the period of time. This may slow or arrest the progression of the disease. There may be antagonistic bacteria which colonize the other sites before AA colonized to the site. These anti-AA bacteria will not allow AA to come and colonize to the site because these organisms colonize the site already. So those organisms prevent colonization of AA. Those organisms may be a simple organism or beneficiary oral organisms which colonize the region, which prevents the pathogens to go and adhere to the sites. Thereby it prevents the progression of the disease. And some statement says that there may be because of the root surface, the denuded root surface or absence of cementum or the connection between the cemento-enamel junction. There may be a gap between the cementum and enamel which results in opening up of dentinal tubules. The bacteria can often enters the dentinal tubules and grow inside the dentinal region, so that there may be growth in only those tooth which there is a gap between the cemento-enamel junction. So this statement was given because the root surface of patients with localized aggressive periodontitis are often denuded. Next is genetic defects in localized aggressive periodontitis. We told that the bacteria evades the host response. Other possibility is the host having a defective immune mechanism which may result in allowing the bacteria to grow. For example, neutrophil chemotactic defect, where neutrophil fails to move to the site of inflammation. Usually the WBCs will run in the bloodstream in the central part. Once there is a stimuli or there is a chemotactic gradient or a signal from the inflamed cell, the neutrophils from the bloodstream pavement to the blood vessels come out, do a chemotactic movement to the site of inflammation. If the neutrophil fails to move to the site of inflammation, there will be defect in the inflammatory response to the bacteria. So a bacteria comes to the site, there will be signals from the site to the bloodstream to send neutrophil to kill the bacteria. If the neutrophil didn't come to the site, the bacteria will grow. That is what happens in neutrophil chemotactic defect. The function of neutrophil is to clearance of infecting organisms and other noxious substance. The abnormality in chemotaxis in localized aggressive periodontitis is characterized by decreased in rate of cell migration in response to the chemotactic gradient, which may be responsible for the localized aggressive periodontitis. So this is neutrophils. So once there is an established inflammation in the site because of the bacteria, the macrophages takes over and kills the bacteria. So radiographic evaluation will show a vertical bone loss affecting usually bilateral symmetrical pattern affecting first permanent molar and incisor. There will be an arc-shaped bone loss extending from distal part of second premolar to the mesial part of second molar. The arc-shaped defect involving the first permanent molar will be a classical sign for aggressive periodontitis, localized aggressive periodontitis. So the clinical features of generalized aggressive periodontitis. When it comes to generalized aggressive periodontitis, we have only very limited information. due to the reclassification in 1999. Before it was called as juvenile periodontitis. Now it was reclassified into generalized aggressive periodontitis. But in 2017 again this classification has been changed. There is no classification for aggressive periodontitis. The periodontitis is not classified as chronic and aggressive based on 2017 classification. So there is very limited amount of data we have with generalized aggressive periodontitis. Only thing is it should affect at least 3 permanent teeth other than first molar and incisor. If it is less than 3 tooth, it is localized aggressive periodontitis. If it is more than 3 tooth, it is generalized aggressive periodontitis. So again, most of the clinical findings will be similar to localized aggressive periodontitis. Often plaque is minimal but contains higher levels of Aggregatibacter actinomycetum committens, Porphyromonas gingivalis, Fusobacterium nucleatum and spirochetal organisms. So it may be episodic in nature. There will be phases of destruction and there will be phases of non-destruction. During destruction there will be severe inflammation, bleeding, suppuration, active attachment loss and bone loss will happen. During non-destructive phase there will be the tissue will appear normal with lack of inflammation. The probing depth only can reveal the disease. Associated systemic complications. Sometimes generalized aggressive periodontitis may exhibit weight loss, mental depression, general malaise, systemic conditions like chronic neutrophil defects, leukocyte adherent defects and functional defects of PMNs, monocytes or both may result in generalized aggressive periodontitis. Usually it will be self-limited once the host mechanisms start acting against the AA. If the host mechanism is not going to affect or act against AA because of the functional defect even in the monocyte also, then there will be progression of disease which results in generalized aggressive periodontitis. So radiograph evaluation will show a severe bone loss affecting a minimal number of tooth or majority of tooth affected with advanced bone loss. This is the classical finding for generalized aggressive periodontitis. When it comes to 2017 classification, periodontitis, the classification have been completely changed. The periodontitis was not classified as chronic and aggressive, but it was classified based on the severity and complexity of management. It is classified into stage 1, stage 2, stage 3 and stage 4. Based on the extent and distribution, it is classified into localized, generalized and molar incisal distribution. So we already seen that localized and generalized classification for both chronic and aggressive periodontitis. Now they classified it as localized periodontitis, generalized periodontitis, molar incisive destructive pattern of periodontitis. So there is no generalized aggressive periodontitis. So generalized aggressive periodontitis again put under generalized periodontitis, not as aggressive periodontitis, right? Based on the staging, it is initial periodontitis, moderate, severe periodontitis with potential for additional tooth loss, severe periodontitis with potential for loss of dentition. So this is what the new classification states. So based on that, the periodontitis have been also graded as based on the rapid progression, anticipated treatment response into grade A, B and C. Grade A has low rate of progression, grade B has moderate rate of progression and grade C has rapid rate of progression. So all this chronic and aggressive periodontitis comes under this grading. So there is no classification as chronic and aggressive periodontitis after 2019. The 2019 classification have modified chronic and aggressive into put inside as periodontitis and classified based on the severity, based on the extent and distribution, and based on the rapidity of progression. So these are the three main sub-classification they have done instead of giving it as chronic and aggressive periodontitis, because there will be lot of confusion if we use the terms chronic and aggressive periodontitis. Some conditions we classify it based on the number of site involved. Other periodontitis we classify based on the number of tooth involved, and it is not with generalized or localized, it is based on the type of the tooth involved. That is what the main confusion between chronic and aggressive identification in the previous classification. The new classification eradicated all those confusion and made it very simple and clear based on the treatment. So based on this staging, the treatment can be performed. So the staging and grading is going to help you in planning out the treatment, whether it is initial, moderate or severe periodontitis, whether it is slow progression, moderate progression or rapid progression. Based on that, the treatment plan varies. So to summarize, we have seen different type of periodontitis, different classifications for periodontitis, clinical features, microbial reactions or reasons for periodontitis, and possible radiographic findings for periodontal disease. The treatment part we will see in treatment classes for periodontitis. Thank you.